and dear fellows. So my topic is Ivus artifacts. And what is the definition of an artifact? It is something observed in a scientific investigation or experiment that is not naturally present, but occurs as a result of the preparative or investigative procedure. So let's begin with some basic images. So this is normal, and all of you who are learning to do Ivus or you have done some Ivus, you will know that you have to identify the adventitia, the media, and the intima. Once you have done that, and once you know that what is normal, you can go on to identify what is a plaque, which could be a soft plaque, or a fibrotic plaque, or a calcific plaque. Now, I am talking here about artifacts, so you might ask that why am I showing you this? Because artifacts you have to see in context. So let's begin with the commonest artifact that you will find in every case, and this is the guide wire artifact. So this guide wire throws a shadow, and sometimes you will see that the shadow is not very prominent, but sometimes it will be quite prominent, like here, shadow, and then here. And now if we go to this calcified lesion, if you look at this calcified lesion, I can't see because of this light. Okay, let me try from here. You can see that there are a number of guide wires here. So this is one, and this is another coming in, and there was another here. So there could be one guide wire, or there could be a number of guide wires. Now, this is the image of this is an image of a dissection, and I will show you the dissection here. So the dissection is here. Just remember these images because we will go on to artifacts after this. This is the image of thrombus. This coming up on the 6 o'clock, not 6 o'clock, sorry, 1 o'clock to 7 o'clock, is a hematoma which is compressing the Ivus catheter. And this is a compressed true lumen, and the catheter is in the false lumen. And I hope by now you can identify the guide wire in each of them. Now, okay. All right. Okay. Okay. All right. So next, I'm coming to stents. Now, remember that you have to understand, you have to identify the stent artifact. So what are stent artifacts? They are shiny structures like this that you will be able to see. And if you cannot identify the stent artifact, you won't be able to diagnose any of these things: under expansion, non-apposition, or in-stent restenosis. And here is a case of non-apposition. And you can see as we are going up, so this is a pullback. Watch this area. And you can see that there is a gap between the stent strut and the intima. So that is non-apposition. And if you look at this, the stent struts are here. And then there is an area out of the stent strut like that, and that is the myointimal neointimal hyperplasia that has caused the in-stent restenosis. Now, We have heard about the utility of OCT in biovascular scaffolds. And when these biovascular scaffolds came, the OCT was getting popular and everyone was talking about OCT. But actually in Ivus, you can also see these BRS struts, and they look like this. So biovascular scaffolds are making a comeback. So if you do not have OCT in your lab, you only have Ivus, don't be disheartened. You can still see them, though not as well as OCT. So let's go to guide wires again. Look at this image. This is the one guide wire that is already there, you can see. And look at those guide wires coming in from the branches. And then there is a third one. So you have to identify these guide wires that are coming into the vessel. And you have heard about rotational catheters and how you have to flush them free of all air. Otherwise, you can get bad images. So this is the normal artery again on your left. And these are two images. In this image, what you can see is, as you start, so this will come back. So you cannot see anything. And then as it is flushed, as I give a flush, then the blood speckle comes back. But on this one, you are flushing, you can't see, you are flushing, but it does not clear up adequately. So in those cases, you have to take the catheter out and flush and then go back again. See, as you go up, it again becomes dark. So calcium and reverberation, if you have a very thick plate of calcium, which is subintimal, and you can't see anything beyond it, it usually means that the calcium is very thick and you will not be able to crack it, and you need calcium modification with rotablation. Usually it is rotablation. Other things, they don't work as well in this type of calcium. And now there is another image that shows you reverberations. This is also calcium in the vessel, but unlike here, you can see reverberations. So these are at the same distance from each other. These are reverberations. And when you see this, it probably means that the calcium plate is not as thick, and this calcium might crack. And this is a patient who had a rotablation. And you can see here that as you go down, you see reverberations here. So it is likely that the rota has acted on this calcific plaque and has made it thinner, as a result of which you can see these reverberations. So I told you about dissection. So the dissection is here, and don't confuse it with side lobes. So side lobes are artifacts. They are not from the central part of the beam, but the image that you see appears like those peripheral parts of the ultrasonic beam. They come from the center, as if they come from the center of the beam. As a result of this, you see the side lobes. So there it is. I will help you to pick it up. There. And this is thrombus and stasis. So I showed you a picture of thrombus. There was the thrombus. But here, this is actually the catheter has gone through a very tight stenosis, and you cannot see the flow, the lumen as well as you should see. And this is not thrombus, this is stasis. Unlike this image, you can see pulsatile flow through this. So if you watch there, you will see pulsatile flow. And it is because the lesion is very tight and the blood distally doesn't clear off easily. So this is thrombus, and this is stagnant flow. Now this is non-uniform rotational deformity, and this again occurs in catheters that rotate. So you have to have a catheter that rotates to have this deformity. And it happens if there is an angle between the left main and the circumflex, a sharp angle through which it has gone, or if it is compressed from outside by a tight O-ring, or the vessel is too tortuous and you can't get that rotation very well. And these are the images that you see, and it is a very annoying artifact because you can't assess the vessel. You cannot see the intima. What are the causes of NERD? So I was discussing that. And look at this vessel. See, you can see the NERD here. And what is happening here, if you look distally, what you are seeing is stasis with pulsatile flow. And then as you come up to the very tight bit, a calcific lesion there is non-uniform rotational deformity because it holds it tight. Here also, you can see NERD here. And you can see this NERD because this very large hematoma is actually compressing the vessel, compressing the catheter, and preventing it from turning round. This is ring down artifact, and this happens with the volcano catheter. And you can see that there is this artifact here. And this artifact you can subtract. But just remember, if you subtract this artifact, then you cannot see structures in that subtracted region. Ivus catheter in the guide catheter, I have only 2 slides left. So Ivus catheter in the guide catheter, if you have a catheter that is coming into the left main, you can sometimes misdiagnose that the catheter, that the left main actually has a calcific stenosis. But that is not the case. You have to be careful. So here you could see this is actually the catheter coming into, the Ivus catheter coming into the guide catheter. And when you are doing imaging of the ostium, left main ostium, the guide catheter should be out of the left main ostium, and then only you will be able to assess it. Otherwise, you will misdiagnose. And before you start, so you've given the flash. Now, there is a button there on the motor drive unit. If you press this, you will get this onion skin appearance. If you do not get this, it means your catheter is still full of air. So once you are got this image, you are ready to go. So I conclude by thanking Dr. Ronnie Matthew for inviting me to give this talk, to the IPCI team for arranging everything smoothly and for their wonderful hospitality, to the chairpersons and moderators and my fellow presenters, and finally to the wonderful fellows who turned up for today's session. Thank you very much.
All right.